Alrighty. Hi, everyone, and welcome. My name's Matt. I'm the Senior Portfolio Manager here at Team Medical. Thanks for joining us today for the webinar titled Stopping Infection in Its Tracks, a Modern Approach to Wound Assessment and Intervention. Firstly, in the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connection to land, sea, and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. At Team Medical, we believe wound care is more than just the product you use. It's about education, it's about awareness, and it's about empowering the healthcare professionals like yourselves who make the difference every day. Would like to extend a big thank you to Advanced Medical Solutions, who supply the ActivHeal dressing range, for making today's educational opportunity a possibility. Before we get started, there's a few housekeeping items that you're probably well aware of. To limit disruptions, cameras and mics are off, but we welcome and encourage you to participate through the chat function. For those that have just joined, please pop in the chat to let us know where you're joining from today, so we know who we're speaking to. Please submit any questions you have throughout in the chat function, and they will be addressed, or as many of them as possible will be addressed during the Q&A at the end. The session's being recorded, and a link will be provided afterwards via email. And before you head off at the end, we have a very quick survey. It'll take all of about a minute. It really helps us guide what topics that you would like to hear about in future. So now that's out of the way, I'm pleased to introduce today's speaker, the fabulous Ms. Hayley Ryan from Wound Rescue, with 20 or so years of nursing experience and a real passion for wound care. Hayley is a clear leader in the field, the former chair of Wounds Australia, and an all-round legend. So over to you, Hayley.
Thanks, Matt. What a lovely introduction. And look, thank you so much to Team Medical for the invitation to come along. Thank you to all of you who have managed to join, which I'm sure is part of your lunch break. So I hope you're at least eating some of the yummy food whilst you're watching this. And I will say I've got some gruesome photos, so just bear in mind if you are putting things into your mouth. So what I do want to talk on today is a bit about stopping infections in its tracks. When I was asked to talk about infection control, it's such a huge topic. So my first declaration to you is that today is really a taste test. So I'm going to go over things quite broadly, but it will give you a good insight. I'm also very humbled that close to 600 people are joining us from around Australia and I think even globally today. So welcome all of you for coming along. Just a quick disclaimer, you can see my details on the screen, but you will be seeing those photos. What I'd like to cover in this morning's session is a little bit about the economic burden in terms of wound care, key signs and symptoms for infections, how we can better collectively manage infections. I'll talk briefly on biofilms, particularly in chronic wounds, when we should refer on, and of course, prevention. So when we think about the economic burden, what is holding us back in the wound care industry is in fact how many people are suffering from a wound at any one time. And I've given you some clear statistics globally of how many people are living with a wound from 2005, which is almost 500 million, all the way up to 2022, where we have now 10.5 million. So year on year, we're seeing more and more people presenting with wounds, and in particular, chronic wounds. In fact, it's estimated that close to 2.5 per 1,000 of the population is suffering from a wound. So it is an issue. In the Australian context, around 450,000 people are affected by a wound, and it's costing us $3 billion to treat these wounds. Now, not only that, these wounds can take an awful long time to heal, particularly if they have other etiologies. But the biggest factor that stops a wound from healing is infections. Now, here's what we know, some quick statistics for you. All open wounds are considered contaminated or colonized, but it does not infer that they are infected. 60% of chronic wounds do have biofilms, and I'll talk a little bit more about that in the next slide. In the acute infection, the pathogenic organisms overwhelm the body's immune system and they penetrate into that viable tissue. Now, the two ways to actually confirm if somebody has an infection is what we call a tissue culture, so a punch biopsy, which gets really deep in order to get that cellular level, or you guys, your clinical observation of 3 or more signs of potential effects of infection can delineate if someone has a chronic infection. Now, here's some interesting statistics. I've been in this field for, 25 years now, and I can tell you swabs were the first go-to many, many years ago when I first started. We're learning more and more about swabs now, and we know that they're showing us less and less information. And I think AMS, antimicrobial stewardship, is teaching us a lot. Now, a lab result requires 10 to the 5 organisms or grams of tissue in order to culture an to culture and determine if an infection is there, which means on a quantitative level, analysing that bacteria, it's not enough. So we are sending off these swabs and it may not be enough to determine if there's an infection. Now, biofilms generally cannot be seen and can only be confirmed by electron microscopy scanning. So what is a biofilm? You would have seen these in the past, I'm sure. These are great graphics, but biofilms are basically, in a very basic fashion, bad bacteria. They sit on the sides of the walls and on the base of the wound, and they secrete this sebaceous fluid, which basically sticks them or glues them to the wall bed, which means that when we come along and we use our cleansing agents, such as normal saline or maybe tap water, it's not enough to actually take the biofilm off. Now, that's a very simplistic view, and we will go into it a bit further into this talk. There are increased risk factors, and one of the documents that I'd recommend you getting a hold of is the International Wound Institute's document from 2022. It's a nice little guideline, a consensus document, if you will, that talks about everything you need to know in terms of biofilms and wound infection. And I have taken this directly from this document because it really highlights quite nicely the risk factors for infection. Now, for example, if we look at the individual risk factors, we know that diabetes puts that patient up there. If they are uncontrolled, they will have a higher risk. Also, peripheral neuropathy, radiation therapy, immune system disorders, and the list goes on. Acute wounds will also have higher levels of concern for infection, and also environmental factors. So I don't know where you're working at the moment, but particularly those of our colleagues who are in the community setting, you are entering environments that are uncontrolled, environments that are managed by the actual patient, and therefore it can cause more disruption to the wound. I'll give you an example. I was at a client's home only the other day, and during the wound care treatment that I was actually doing, in came her 2 puppy dogs to have a look. So we have to be mindful that will increase risks. The other part of this document that I really, really like is how simplified they have looked at the wound infection continuum. And what they can show here is that there are 5 stages. So your general contamination, colonization, local wound infection, and then spreading up to systemic infection. So in general contamination, it might be a little bit red. It might have some swelling. You might have more purulent exudate. It doesn't necessarily mean that you require antibiotics at this stage. But certainly if the patient is showing malaise, lethargy, loss of appetite, fever, severe sepsis, septic shock, all of these things here do require systemic treatment. So whether that be oral antibiotics, IV antibiotics, whatever it might be, depending on the patient. What my key message is here is that not every wound that shows a bit of slough and a bit of redness requires action with an antibiotic. And that's the key message I want you to take home. So the question is, how do you assess a wound for infection? Well, I'm going to present to you two quick mnemonics that have been around for a very long time. The first one's called NERDS, and you can all Google this and look it up. NERDS has been used for a very long time, and it looks at, is the wound non-healing? So it's not progressing as expected. Is there increased exudate or abnormal wound drainage? Is there red and bleeding, especially in the wound bed? Is there debris, such as the presence of necrotic tissue? And is there a foul smell? This could be an indication of an infection pending. The other mnemonic I want to introduce you to is that of stones. And stones is similar to NERDS, but looks at the size of the wound, the temperature, is there any bone or tendon? Is there any new breakdown? That erythema, and again, smell. So there's two tools, and of course there's plenty others available that you can use, but I thought I would show you two of the main ones that I see being used. Now, why is infection in the wound, why does it matter? Well, wounds are an entry point for infection because they're often open. There are high-risk populations, particularly the elderly and the immunosuppressed. It is linked to increased costs, morbidity, and mortality. And we can actually prevent a lot of infections with good practice. In fact, effective infection prevention can reduce healthcare costs by up to 30% and significantly improve the patient's outcomes. Now, I know that all of you health clinicians online have seen this multiple times. This is our chain of infection. We know that there's a portal of entry, you have a susceptible host, infectious agent, the reservoir, the portal of exit, and the means of transmission. And the circle, the chain goes on. And the only way to stop that is to break the chain of infection. Well, let me put it into the context of wound care. So if we think about the portal of entry, that could be the wound or the skin. The susceptible host is often the immunocompromised person. The infectious agent is often bacteria or fungi. The reservoir is usually wound bed equipment. Portal of exit could be the exudate and drainage, and the means of transmission, contact or droplet. Now, I wanted to present to you here what it looks like from a wound perspective when we talk about this chain of infection. So thinking about that now, you need to start deciding, how can you break that chain? Could I, for example, before we even have a break in the skin, manage the skin with appropriate moisturizers or barrier creams and stop it from breaking down? If somebody's immunocompromised, how can I get on board with supporting their unstable diabetes? How can I manage exudate, for example? But these are the things we can do to stop a wound from getting worse and getting an infection. Now, when we talk about standard precautions in wound care, this is what the Department of Health within Australia recommends. Hand hygiene, I think you all agree with that, before attending the wound, after removal of gloves, that you have your appropriate PPE on based on that risk assessment, that you make sure you clean the environment. So think about the dressing trolleys, and we'll talk about that shortly. Waste management and sharp safety. And if we can manage these in all contexts of healthcare, we certainly minimize the risks of infection. I don't need to go through this. I know it's all been drilled into you, that 5 moments for hand hygiene. And I've just put on the screen a couple of examples when it comes to wound care, what we should actually be thinking about. Now, how do we dress a wound and what are we using? Is it aseptic technique, for example? And I hear that a lot. My staff aren't doing aseptic technique. Well, that's really for sterile environments and sterile areas. So what we want to really focus on is that non-touch technique. So it really starts at the start when you've washed your hands, you've put your gloves on, you've set up your trolley, and you've gone corner by corner to get your dressing pack out ready to go. Now, sterile gloves are recommended for deep wounds or surgical site wounds. You do want to have clean fields. As I said, focus on that dressing trolley. You want to make sure that you clean to dirty sequence. And what that means is, you know, if you think about your dressing pack, they often come with 3 faucets. Make sure they don't cross over. Use one to stay dirty and one to stay clean. Think about the environment. Can you control the airflow? Can you minimize traffic? As I said a moment ago, can I stop those dogs from coming in? Manage the disruptions, and that will also help. Now, when it comes to transmission of extra precautions, such as if you've got a patient who has MRSA, VRE, all of these higher end issues with a wound, gloves and gowns are in fact recommended. Single rooms where possible, limit patient movement where you can, and make sure you use dedicated equipment. Now, some of you might be from a residential aged care facility and say to me straight away, it's impossible to have a single room, it's impossible to manage all of this. Well, just manage what you have in your control. So gloves and gowns is an absolute must for any of these patients. When it comes to cleaning and disinfecting, I want to ask you all, how often does your dressing trolley get cleaned? Is it just the top of the trolley, or do you make sure you go down the sides, for example? Now, I'm going to ask for a little bit of audience participation here. I'm going to show you a trolley, real world trolley that I've seen and taken the photo of many, many years ago, this first one, but I want you to assess it. I want you to tell me what you believe is wrong with it, what you can see is inappropriate, or if you're quite satisfied with it. Here it is. What do you all think? Drop some things in the comment section for me. Are you happy with this trolley? Do you see any concerns? Too full? Yep, not cleaned correctly. Clutter? Okay. Too cluttered, can't be clean. It's rusty. Good pickup, whoever said that, well done. You can see an open bin. Okay, it's messy, it's full, it's rusty. Spot on, spot on. You guys have got it. So, unfortunately, this was an actual trolley being used within a home that I went to. Yes, you can see some rust. It is definitely too cluttered. This actual bin was actually not a rubbish bin, but full of cotton wool so that you could clean the wound. And we know that's not a practice we do. We don't use cotton wool because the filaments, and the box underneath happened to be the rubbish bin. I think you all agree it's not an appropriate use of a trolley. What about this trolley? And again, give me your feedback. What do you think's wrong with this wound care trolley? Crowded top, yep. Overstocked, again, no room, not enough room for dressing pack, too cluttered. I'm waiting for someone to pick up here what it is. Not fit for purpose, porous surface, absolutely. Nobody's actually picked up, or I think somebody, yep, somebody did. It is a medication trolley. So this particular service thought a good way to save space was to have half the trolley full of dressings and the other half full of medications. And I think all of you online would agree, not appropriate. So what about this final trolley? What are your thoughts? Perfect. Great. Look at the differences coming in. Suitable, excellent, good. Yes. I'm waiting for someone to say, but there's no drawer. Oh, there we go, Tammy, thank you. No drawer. Can I tell you, I'm not black and white where we have to say, that's it, no drawers. But what I do say is when we do have a drawer, it does bring us back to temptation. You're all extraordinarily busy people. And it is absolutely impractical to do what is highly recommended, which is to get one dressing, go to the one patient, do the one wound, come back, repeat, etc. I get it. But to put everything into a drawer can create issues for contamination. So just be mindful and always risk assess. Which then brings me down to the roles of antimicrobial stewardship. And I would make a reference here to the European Wound Management Association document, which has some great information purposely for wound care and managing AMS. We know now that we do want to limit unnecessary antibiotics. So I'm looking, as soon as I finish writing up a few papers after August, doing some trials on doing swabs, because what are they telling us? They don't actually tell us that somebody has an infection. The wound swab tells us what bacteria has grown, what antibiotics are they resistant to. And then often we find that the antibiotics has already been charted before I even have the results. So is there any purpose in actually sending off a swab? And is there any purpose in charting or giving antibiotics if they're not systemically unwell? So watch this space for that. But what I would say to you is be cautious. If they're really not unwell, manage the wound topically. Can you use an antimicrobial dressing, which is going to give you that topical treatment? And then, of course, involving the patients in their journey is so crucial. Educate them on hygiene. You know, one of the biggest things I see missed with a lot of patients is basics of nail care. Dirty nails, long nails, chipped nails that are really, as soon as they start scratching, because a lot of them have got dry skin and it's itchy, they start to break it down, they get cellulitis, or they can cause infections. You want to report the signs of infections to the patient. What do they need to look for? Redness, heat, swelling, pain, talking them through what to look for and giving them clear wound care instructions. What I'm getting at is patient empowerment is so crucial, and it will in fact help you as a clinician to manage their wound. Now, let me ask a couple of questions of you. Is this wound I'm about to show you, and this is the gruesome part, so if you're all having a wonderful lunch, be mindful you're about to see wounds. Is this wound infected? Yes or no? Do you think there's signs of infection? Michelle says yes, yes. Yep. We're getting loads of yeses. You're absolutely right. This was an infected wound and they were systemically unwell. So we did give them an antimicrobial as well as antibiotics. What about this wound? Necrotic edges for sure. Yes. So we're getting a lot of yeses. And again, this was infected, but we treated it, in fact, with just antimicrobial dressings and didn't need the antibiotics. And the last one, what do we think of this one? Infected or not? But a couple of no's this time, a couple of yeses. And I had a feeling you might say no, but in fact, this was actually really, this was an infection and they were systemically unwell. So we provided an antimicrobial as well as antibiotics. Sometimes infections can present very red. Yes, you can see the ligaments there, but very redness can also be a sign. And the final photo can be a bit gruesome. So if you're eating, be mindful. What can we see here? There we go, maggots. Yep, we've all seen them before. There are maggots between the toes. Now, maggots are from flies. Flies lay larvae, the larvae turn into maggots. Flies land on odorous wounds because that's what they're attracted to, off meat. Now, the problem is if we don't manage the odor in a wound, this could be a potential for you. Now, this wound didn't need antibiotics, but we did treat it topically. But our focus here, as you can see up the limb, was to really give it a clean, not just the wounds, which is here, and there was one in between the toe, which is covered by the maggots, but up the leg as well. So giving it a good clean. Now, there are new things coming on the market in terms of innovation, and I thought I would just show you two very quick ones. This is a fantastic product and Team Medical actually have this available for you. It's only recently come into the country. It's called Moleculite. It is a fantastic product. I have used it myself. Basically, it handles imaging devices to detect fluorescent bacteria. So you hold the camera over the wound and it will tell you how far that bacteria goes. And what we're now seeing, watch this space, you're going to start seeing loads of information coming through in research. We are so used to and accustomed to washing the wound, but how many of you wash outside the wound? And what we're seeing is often that bacteria is living 20 centimeters or more outside the wound bed. So if we don't focus on cleaning the wound and then going outside of that area, you are going to have more problems with it breaking down. I love that, but what's the price? Everyone wants to know the price. I always say, what price do you put on a patient's care? But realistically, look, they can be expensive, and that's the problem with all innovation products. They are expensive, they're not for everybody, but if you can find quality improvements to prove you need it, maybe that's an opportunity for you. These are just taste testers, guys. And the other one is photobiomodulation with blue light. I've done loads of work using this device. I find that the photobiomodulation basically gives blue light. It's absorbed by the electron transport chain enzymes and over to the flavor proteins, and it basically breaks down any bacteria. I found during the trials we did that it also controlled and reduced infections. You hold it over the wound, you take a photo, like a photo, for about 30 seconds, and then you do that once a week. That's it, like a fake photo, it looks like. But it's, again, another great product, but again, not for everybody. There's loads of evidence, which I won't go into today, but would love to talk to you a bit more about it later on. And I know Matt, who's on the line today, really knows both the molecular light and photobiomodulation products as well. So preparing the wound bed for success is your best way forward. And again, I'll point you over to the International Wound Institute document that really outlines how do you manage a wound, and that is with your universal precautions, selecting the appropriate technique and thinking about how you clean. And I'll also introduce you to this other consensus document, which really sets the wound bed up for success. I really like this simplicity. It talks about 4 steps. Cleanse the wound and the peri-wound skin, as I said, up to 20 centimeters, debride the wound, refashion the wound, and dress it for success. Now, I want to briefly end a couple more slides with one really important topic, and that is the topic of debridement. Now, firstly, in Australia, our regulations state that you have to have specific training when it comes to debridement, but that's sharp debridement. Everybody on this call today can do some form of debridement, and I love this ladder for debridement. So it starts off with your autolytic, selecting the right product, your biological, which is your maggot therapy. But the one where I see you all sitting really nicely is that mechanical debridement. So using things like the microfiber cloths that you have available now, wetting them and giving the wound a really good scrub. Some of you may have experience in curettage and also scalpel work. That's how I do my debridements. But please, mechanical debridement with most chronic wounds is crucial. Now, of course, there's limitations to mechanical debridement, which is why you need to call us in and refer early so that we can come in on and do that at your site to do the debridement. The limitations are simply this. Looking at this wound here on the screen, could I mechanically debride it? What do you think? No. Absolutely not. You're spot on, guys. This is too far gone. But where you need to focus your efforts, look at this wound here. This is probably one of the most severe cases I've seen. This is your hyperkeratosis, which is that buildup of that keratotic tissue. And if we had started early enough and really scrubbed the area and around the wound, it wouldn't have got to this place in the first instance. Now, what I want to tell you about debridement, there is lots of evidence in this space. In fact, surgical debridement alone does not adequately reduce that plant tonic bioburden in chronic wounds. So what I'm getting at is this great study here showed that you need to do multiple debridements to reduce the biofilm and actually successfully start to heal the wound. So we recommend it every dressing change. And the reason is there's a tolerance of biofilms, particularly against antiseptics and antibiotics. The debridement basically will crack the biofilm matrix, so you get this new surface, but repetition with sometimes antiseptics or antimicrobial dressings will stop them coming back. So you have to think about how you do it. Now, this is just a quick little video of showing you a curette debridement. And the reason I'm showing you this is because if you weren't seeing me debriding this, you would think that this wound bed was okay, and you would maybe perhaps keep putting a dressing on top of a dressing on top of a dressing. But that dressing will not break through all of this gelatinous muck. And that is why we come out and we will do a debridement for you. So a quick question. In this photo, could we debride this or could we not debride it? Debride or not to debride? Yes, absolutely we could. What about this wound here? Could we debride this wound? Okay, we've got a switch. No, no, no's. Absolutely not. And you're spot on. Whilst there's some granulating tissue around the side, you can clearly see a ligament. And my final photo, could we debride this wound, which is on the sacral area? It's got some of you thinking. Some are saying no, some are saying yes. Well, in actual fact, this was a recent one. And this was done at the bedside in the community where I've gone in and debrided. And this is the wound now. We're actually almost healed that wound. So has been a great success. So to finish up, my takeaway messages is that everyone is responsible for managing good stewardship around infection control. Using aseptic or non-touch technique, practice good antimicrobial stewardship, use standard-based precautions, clean your environment, particularly those pesky trolleys, and engage patients along the journey. Here are some of the key documents that I've used today, which you'll be able to get access to with some online resources. And with that, I thank you very much. If you want to stay in touch with Wound Rescue, there's our socials, and I will now hand back to Matt. Thank you.
Thank you, Hayley. That was pretty impressive, especially some of the cases. And also thank you to everyone that's participating in the chat. This is much more enjoyable and I think a lot more valuable as an interactive session. Feel free to obviously follow Hayley's organisation on whatever platform you prefer, or maybe all of the above. As part of what we supply at Team, we have some of our own products that we would like to sort of put forward to you out there. Some of you may or may not be familiar with a product called microdacin. Sort of when it comes to infection, adopting evidence-based best practice will always ensure we get the best patient outcome. Self-selection is second to what evidence suggests. As it relates to wound irrigations and sort of antiseptic solutions, there are a few products that are more proven than microdacin. It's a formula of a superoxidized solution with its active component being hypochlorous acid. It's completely non-toxic. It's safe for all wounds. It has no contraindications. And most importantly, it's clinically proven in a raft of clinical trials. Randomized controlled trials are some of the highest evidence we have in medicine. And microdacin is proven head-to-head against things like betadine, which is considered to be really quite effective, but also quite toxic. And so multiple randomized controlled trials suggest that microdacin will treat and prevent infections better than betadine. More recent research looks at comparing microdacin in chronic wounds to other solutions and formulas that you may be more familiar with. Clinical trials report that microdacin achieves a higher reduction of the bacterial burden in chronic wounds when compared to things that have surfactants like Prontosan. And finally, maybe more of an interest point, the Harvard Medical School reported on their own trial that compared microdacin with oral antibiotics and saline to find that the topical solution alone was more efficacious at treating mild infections of the diabetic foot. So based on just this quick flavour of the data, and obviously Google will take you much deeper. If you've got wounds that are infected or they're not healing or both, we would encourage you to trial microdacin. It's very simply integrated. I'll sort of leave it at that. But switching back to the session itself, we've got a quick Q&A, and please keep the questions coming. Probably the first one here, Hayley. One of the speakers has asked, can you speak a little bit to not using antibiotics if the wound's infected, but the patients are not systemically unwell?
Yeah, good question. So the question I'd ask is, when we're dealing with wounds, we look at the wound bed itself and around the area and we go, okay, is there lots of exudate more than last time? Is it very purulent, yellow perhaps? Is there redness often spreading by 4 centimetres outside of the wound bed? Is there maybe an odour? In other words, are you seeing some local infections? The next question you would ask yourself, is the patient themselves unwell, for example? Do they exhibit a high temperature? Maybe they're not eating as much. Maybe they're quite lethargic. That would potentially indicate a systemic infection, at which point antibiotics would be suitable. But if you just have the local signs of infection, then maybe an antimicrobial is the suitable product. And I'll just jump on the back of that microdacin topic that Matt just spoke about. We've really come a long way in the wound care industry. Normal saline, we're rarely using now, more for your skin tears, you might use some normal saline, but anything else, we're particularly using things like microdacin. In fact, I had a little giggle. My husband was bitten by a dog very recently, just a very small bite on his finger, but I'm treating it with microdacin and it's working. There's some fun facts there.
And fantastic. We've got, I guess, quite a lot of product questions that I sort of assumed would flow in after that, but there's some questions in here about the use of things like peroxide. What's your stance on these sort of older antiseptics?
Look, antiseptics are still around. We still use them, but very rarely. And I'll tell you one of the main reasons is because often they sting the patient. They hurt the patient. And we've got so many better products, as you've just seen, the microdacin, for example, with the betadine, which do not hurt the patient. So I'd have to ask, why are we going for more antiseptics that not only hurt the patient, but they also tend to dry the wounds out? And if I just talk briefly about iodine, for example, we used to use it all the time. Remember the old swabs? We'd put them on a wound. We certainly don't do that anymore. They really dry out the wound quickly. They are toxic to some degree. In fact, the recent, well, not so recent anymore, but the 2018 guidelines for skin tears really stipulates no iodine-based products on skin tears. So you've got to really pick and choose and know your product well. Hopefully that's answered.
I think that was pretty comprehensive. I'll just address all the questions that are coming in the chat. There's a lot that are asking about differences between prontosan and microdacin. I think that's probably beyond the scope of this. As it relates to silicone products, can you share your experience with silicone versus regular foams?
We've come a long way with silicone. We've seen the absolute benefit, particularly those with vulnerable skin. And I'm not just talking about the elderly, which by definition in the research is over 65, but also children as well, or those that are immunocompromised because their skin breaks down easy. Silicone really provides a product that can go on nicely, come off nicely, and not cause trauma. So from that effect, it works really well. In fact, for skin tears, generally a silicone product is my first choice. Foam dressings, I'm finding that I use them less and less, but before you jump to that, I'm seeing more very, very complex cases that have loads of exudate, and foams only hold a moderate amount depending on the foam, of course. So you have to really risk assess. Now, I know we jumped over the prontosan versus microdacin topic, but I want to talk very quickly clinically. One you have to put on for 15 minutes. The other one works within 90 seconds. And I know all of you are too busy to, unfortunately, wait around for 15 minutes. So there's some of the clinical decisions I make when I'm picking a product. So you have to risk assess all the time. Back to you, Matt.
Fantastic. That's great, Hayley. I think we should probably also maybe tap them off there. Thank you all for the questions coming through. There are so many, we simply can't get to all of them. Please keep in touch and keep an eye out for the next series of these webinars, or reach out to Hayley directly if your service needs sort of the advanced modalities that her and her team have on offer. But thank you, Hayley. Awesome presentation. It is clear that the the response here has been pretty fantastic. And again, thank you to all those that have participated. Tomorrow, you'll receive an email from Team Medical with the PDF certificate, as well as a link to the recording. But we're wrapping up now, so please feel free to fill out the SurveyMonkey questionnaire that's in the chat. Tell us what you'd like to hear about next time. Otherwise, thank you all and have a lovely afternoon.
Thanks, everyone.